Ladies and gentlemen, may now invite this session moderator, Professor N.N.Khanna, to have his presentation on endovascular management of hypertension for the next 11 minutes. Professor Khanna, please.
I must thank Dr. Chopra for inviting me, and also the Brahma Kumaris. It's a real divine experience to be here for the second time. I'm going to speak something about endovascular management of resistant hypertension. Please excuse me for the bad cold which I have. Now, if you see hypertension in terms of epidemiology, only 30%, 35% of the hypertensives really have well-controlled hypertension on medication. Another 35% have treatment, but they have uncontrolled hypertension, either because the hypertension is resistant or they are on suboptimal doses. And 30% of the hypertensive population all across the world dramatically do not receive medications at all. If you see, these are very striking data from entire world. 53% of the patients in US do not have successful or treatment of hypertension or an optimal treatment of hypertension, and it is practically the same in Europe, in Greece, in England, in Canada. And if you see, if you really extrapolate, India would be about 70% of Indians would not be having appropriate or optimal treatment of hypertension. What is also very important is, if you see, for every 20 millimeter systolic and 10 millimeter diastolic increase in blood pressure, there is an increase, twice 100% increase in mortality at cardiovascular mortality at 10 years. And another very interesting point is, if you can even decrease the blood pressure, systolic blood pressure by 2 millimeter of mercury, you actually can decrease the risk of stroke and mortality because of stroke by 10%. And 7% reduction of ischemic heart disease mortality. So reduction of blood pressure and optimal control of blood pressure is the most important thing. And why we cannot achieve is either we do not diagnose it, or we do not treat it adequately or optimally. And many a times we have what is known as resistant hypertension, the definition of which has been given in the previous presentation. When you have BP, you cannot control BP in spite of three antihypertensive drugs given in optimal doses, and also one of which is diuretic. And mind you, this treatment plan must include lifestyle modification, what we follow here. In spite of that, if the hypertension is not controlled, and maybe now the fourth drug, the eplerenone, then these patients are labeled as resistant hypertension. And in most of these cases, the cause is sympathetic nervous system or sympathetic overdrive. Now, if you see, the sympathetic nervous system supplies catabolic signals to the body, acting wherever and whenever rapid response to environment is needed, and this will lead to acceleration of the heart, increase of coronary cardiac output, dilatation of coronary vessels, increase in arterial blood pressure, and increase emptying of blood reservoirs, and dilating of bronchus, and releasing of glucose, and inhibition of GI activity, and many more. But what is very important is, if you see in different types of hypertension, whether patients have white coat hypertension or borderline hypertension or essential hypertension of any grade, most of these patients would have increased central nervous sympathetic drive. Also, what is very important, if you see the renal sympathetic activation in these patients of hypertension, you will almost always find that there is an excessive renal epinephrine spill in these patients. And therefore, it was very prudent to think that if we sort of do a sympathetic denervation of the renal arteries, maybe this may work. And this was first done in 1932 by the surgeons who did sympathectomy to control blood pressure. And then again in 1953, this surgical treatment became popular, but then it was lost because it was surgery. And only in the last one decade that somebody thought that we can achieve the same thing by a catheter, and maybe this works. And it actually did work in the concept, but in one of the trials it failed. What it means is that if you can denervate the renal arteries, you will have blockage of both efferent and afferent signals going to the brain and coming from the brain, and this will decrease the overall sympathetic drive and decrease the systolic blood pressure and also the diastolic blood pressure. If you see the anatomy of renal arteries, you have the sympathetic fibers going into the adventitia, and if some way we can go through the lumen of the renal arteries and denervate these sympathetic fibers, we can achieve this. And this was first done by the Symplicity catheter, which required radiofrequency ablation through the lumen of the renal artery. And this was a one-point contact, and the catheter had to be rotated like this in different directions and at different points. And this would denervate the renal artery in a majority of cases and bring down the sympathetic blood pressure. If you see, this is the zone of oral radiofrequency treatment. If you see on the staining, there is a coagulative necrosis of the sympathetic fibers. And if you see staining of the NF protein immunostaining in these patients, you find that both in acute and chronic stages, you have permanent denervation of these sympathetic fibers. If you see the preclinical efficacy, this was done in the swine model, 300 swine models which had renal artery sympathetic denervation. In most of the patients, there was adequate renal artery denervation without any vascular injury to the renal artery. There was also blunting of the BP response by an electrical stimulation of the renal arteries, thereby proving the hypothesis that renal artery sympathetic denervation done by endovascular means actually works, and this worked in the animal model, and that is why the first in-man study was done, and it was published in the New England Journal of Medicine in 2009. And this was a patient, a 59 years old male, who was not controlled on 7 antihypertensive medication. His baseline medication, BP on 7 antihypertensive medication was 161 by 107, and this patient had a successful sympathetic renal artery denervation. His BP came down to 141 by 90. The number of drugs required to control his blood pressure came down, and this was quantified more scientifically by decrease in the norepinephrine renal spillover, decrease in total norepinephrine spillover in the body, by decrease in the plasma renin activity, and also by increase in the plasma blood flow and decrease in the left ventricular mass, all of which was significant. And this led to a lot of enthusiasm, and this first-in-man study actually led on to number of pilot studies, the Symplicity Hypertension 2 and the Symplicity 3 trial, and which was done both in US and the European Union. And this was done with the Medtronic catheter, but it was very exciting, and we were expecting that this is going to work. But because of many problems in the trial itself and the design of the catheter, the trial actually reported negative results. It did not report any superiority in terms of decreasing the blood pressure in a significant way, and it failed to reach the standards. Now, this trial was analyzed, and we found that the way the renal artery denervation was done was not correct. There was a lot of selection biases. The patients which were randomized were not done properly, and we have a series of there is a sort of a interest which is coming again. There is a series of new catheters and new catheter designs which can work with more uniform denervation of renal arteries. And many companies have come forward. This is St. Jude's Enlighten system, which works on multiple electrodes. We have Boston Scientific's VEX6 system, which has multiple bipolar catheters in electrical electrodes, which would circumferentially denervate the renal arteries. We also have one from the Covidian, which is one shot system, which has a helical design, which will again denervate more of renal arteries. And we have a system from the Recor Medical, which simultaneously cools as well as heats, so it will denervate the renal artery sympathetic nerves, but it will also at the same time not produce any injury to the intima and media. So I'm not going to go through the details, but what is very important is there is a resurgence of sympathetic denervation of renal arteries by Bather catheters, and the time is going to tell us whether this therapy is again going to come in common use or not for resistant hypertension. The other way to treat hypertension, resistant hypertension by endovascular means is to work on the carotid sinus, which is the baroreceptor. And if you stimulate the carotid sinus, what it does, it will decrease the blood pressure and the heart rate. And you can do that by two mechanisms. One is to pace this like electrical pacemaker, or the other one is to put a self-expanding stent, which then would give a radial stretch to the carotid sinus, and this will stimulate the vagal nerve and also increase the parasympathetic activity and decrease the sympathetic activity, thereby reducing the blood pressure. So this is the mechanism, and this has been now tested in human beings, and this is how we do it. We put a pacemaker-like device into below the skin, and then you stimulate the carotid receptors, or we do a self-expanding, put a self-expanding prosthesis, which comes in 3 sizes, from 5 to 11.5 millimeter in diameter. And this is from the Mobius. It is known as the Mobius HD device. What it does, it will expand or put a radial force on the carotid sinus, and this will decrease the sympathetic activity by stimulating the baroreceptors, and will also increase the vagal activity as a reflex mechanism. Now, 9 patients have been studied, and this was the first trial which actually went through exemptions in FDA and directly went to the trial. And it was a safety trial, and it was found that it was effective. There was at least 30%, 30 to 33% reduction in systolic blood pressure, and it met the safety standards. 4 out of 9 patients required reduction in medications, and there was one procedure or device-related adverse events, and this was related to the vascular site complication and nothing with the blood pressure or the carotid sinus. And this, so in the end, I would say that endovascular treatment of resistant hypertension is a reality. It has, there are 2 ways we can do it. One is to denervate the renal artery. The other way is to work on the carotid sinuses and either stimulate them electrically or put a self-expanding stent. The Symplicity 3 trial as of now failed to meet the endpoints, but there was a lot of fallacies in the trial, and the new trials are on with newer devices. And the first-in-man study, which was the CALM first-in-man study, which with the Mobius HD self-expanding stent, met the safety standards, and now a bigger trial is on the way. So if you have patients who fail 3 antihypertensive drugs, or maybe the 4th one in optimal doses, there is an endovascular mechanism of treating this, a way of treating these hypertensive patients in future, and I'm sure in future these devices would be widely available. Thank you very much.
Yeah. That's a very elegant talk, and the first thing is that renal denervation is presently down, not out. There has been a lot of research about where actually the nerves are located in the renal arteries. There's a paper by Dr. Renu Virmani's group in which they've analyzed the position of the renal nerves in the renal arteries. And what they actually find is that the maximum concentration of the renal nerves is actually in the proximal portion and the mid portion. Whereas those of us who've attended the denervation course, as I also did, you must also have, they used to tell us to start from the distalmost part and come back. So we were actually probably wrong in the approach. Plus, there have been a lot of improvements in terms of selection. They've found that the blacks do not respond very well. The non-blacks do. Secondly, if you are on a vasodilator, then also you respond badly. I mean, if you're not on a vasodilator, then you respond better. Likewise, if you've been on spironolactone and you have failed, then your chances of success are much better. So both in terms of better understanding, and as you said, there are different catheters that are now available. There are different means actually. People are trying ultrasound to deliver that energy to ablate those nerves. People are trying even micro injections of alcohol. So all those are there, and very well said. RDN is actually down but not out. And the greatest thing is that Symplicity 3 told us that at least it is a safe procedure. The safety aspects were completely met, and it is a safe procedure, although it failed on the efficacy aspect of it. Okay. And between the BAT, the baroreceptor augmentation therapy, and using a self-expanding stent, I think BAT is a better established therapy. So, and now unilateral BAT is also available. The RIOS had to be used bilaterally, and it was to be done surgically. Now you can do it endovascular, and you can do unilateral. So that is another important mode of therapy. Thank you very
Thank
much.
you.
So there is a lot of exciting era in future, and I'm sure interventional cardiologists are going to treat hypertension in a different way, especially the patients of resistant hypertension or patients who cannot take drugs because of side effects.
Thank you. Thank you very much, Professor Khanna. Please have your